everyone, and welcome to the 6th HPS presentation series. Our focus today is on training of trainers. So just to let you know that as attendees, you're all currently on mute, so I can't hear you, but if you do have any questions, you can type them into the question box at the bottom, and we'll try and help. So I'm Carmel, I'm a Research and Evaluation Officer here at THET, and I'm also joined remotely by Laura, who is the Country Programmes Coordinator, and we'll be introducing the presentations and making sure the technical side of things runs as smoothly as possible. So we'll also be posting the recording of the webinar on our YouTube and website, so you don't need to take any notes, and there will be time for questions at the end, so if anybody does have any questions, you can either wait to the end or, again, post them in the questions box. So today we'll be hearing about the research into the training of trainers model, an approach that a lot of partnerships use and is quite fundamental to many projects. We'll also be hearing about the experiences of 3 health partnerships in their implementation of training of trainers. The presentations will cover what works and what doesn't in implementing a sustainable training of trainers programme, some common issues in achieving an active training of trainers programme, and finally some issues around incentives. And we really hope that the partnerships can learn from these experiences and hopefully avoid any problems in the future. We do only have 1 hour, so I would ask that each presentation is kept to 12 minutes, and we might have to cut people off if it does run over, just because we do need time for questions at the end. So I will take all the presenters off mute for a second. Do any of the presenters have any questions?
No, that's good.
Okay, no questions. So we'll start with the first presentation. So I'd like to introduce Dr. Maru Mormina, who is a senior lecturer at the University of Winchester. And Maru is going to introduce her to her research on training of trainers and the TRAIN framework. So over to you, Maru.
Okay, well, thank you very much for giving me this opportunity. Yes. As Carmel said, I'm a senior lecturer at the University of Winchester. My research is mostly concerned with capacity building and research partnerships, but I was very interested in looking at global health partnerships to see what lessons can be learned in the research community. So I'm very grateful to THET for giving the opportunity to do this piece of research in partnership with them. Training programs typically combine elements of learning in the classroom with learning by doing or learning on the job. A very popular training strategy in development is the training of trainers or taught approach, because it seems to be cheap, effective, and self-sustaining. Basically, a taught starts a cascade of training, skills, and knowledge are taught to a small group of trainees, who then go on to become trainers and transfer those skills to others. However, there's not much research into what makes a taught intervention successful. There's also little evidence to guide partnerships on how to achieve success. It's commonly assumed that taught is a strong predictor of sustainability, precisely because of its potential for upskilling the workforce rapidly, cheaply, and exponentially. But this depends on the training cascade proceeding swiftly and unimpeded by other factors. So I wanted to know what are these factors that can help or hinder partnerships' ability to achieve these goals. So the Health Partnership Scheme gave me the opportunity to analyze the different factors that may be at play in taught interventions, precisely because partnerships are varied in size, as you know, in scope, and in the context within which they operate. So I expected to identify lots of context-specific issues, but also some common themes. I selected the medium pair institutional partnerships because I thought this can be more representative of the typical taught intervention. I did a content analysis. I looked for common themes across narrative reports and other material that was available for each partnership. I also did a literature review alongside to inform my analysis. And from all these, I identified codes, grouped this into categories, and these into themes. So I found a number of factors affecting taught interventions and grouped these into 5 main themes. I gave these groupings names that make together the acronym TRAIN. So these main themes constitute the basis of a framework or model for taught interventions. So what are these 5 key constitutive elements of a good taught? Well, first of all, the trainers, master and the trainee trainers or local trainers, i.e. the talent. Secondly, the resources available to conduct the training. And by resources, I don't only mean physical resources, but crucially time resources. Third, the relationship between the objectives and the outcomes of a training and the local priorities, the wider strategic plans, the institutional and political context, etc. That's the alignment. And how taught is used by local institutions to achieve their goals, the implementation. And finally, the post-training phase, what happens after you complete a taught, and how the newly trained trainers are supported to continue the cascade. These 5 elements operate across 3 different levels: the individual, the organizational, and the super-organizational. That is the level of institutional network, national and international bodies, and policy environment. A successful taught will develop these 5 elements at all 3 levels. The arrows that you see point in both directions to indicate that what you do at one level can have an impact at all other levels. Underlying the whole framework is the notion of sustainability. Here the idea is that the constitutive elements of the framework contribute to the self-sustained and long-term training capacity of the organization receiving the taught. Now, in the rest of the presentation, I want to take you through each one of these 5 elements very briefly. So, the first one is talent. The main goal of a taught is simply to train participants to become trainers. So both master trainers and local trainers must have the right blend of skills, experience, and knowledge to train others. That's the talent. Professional experience is important, but perhaps more so is the ability to pass this experience to others. Partner institutions should have procedures in place to identify potential trainers, both master trainers and local trainers, for example, through pre-recruitment aptitude tests. Local trainers' long-term commitment to train is really, really important to avoid the high levels of attrition that are common in some developing countries. At the super-organizational level, policies and incentives can be introduced to help talent recruitment and retention, for example, professional accreditation, benefit packages, progression paths, etc. Second one is resources. At the individual level, time is the most often reported limiting factor. For local trainers, time to attend a taught course and to cascade it afterwards is a major disabling factor. Master trainers also experience time constraints, usually having to fit overseas volunteering during their annual leave or around full-time and very often highly demanded jobs. Financial resources or lack of financial resources can also hinder taught participation, particularly for local trainers who often need to make complex travel arrangements and make personal disbursements. And here is where institutions play a huge role. They need to be, first of all, willing to release staff from their normal duties. For high-income country organizations, this can be seen as a burden, although the benefits of volunteering are well documented. For developing country organizations that typically face understaffing, it's really important that they integrate the taught within the wider strategic plans. And this can be done by adequately identifying local trainers, which should also include an assessment of the capacity of the organization to absorb the workload once the individual is released to conduct the training. There's often an unspoken assumption that the developing country partner will help cover recurrent costs, for example, refreshment, per diems, equipment, travel expenses, etc. That's not always the case. That the developing country partner can or is willing to absorb this cost. So it's important that from the outset there is shared responsibility, transparent financial arrangements, and clear commitments, so that to avoid imposing undue burdens on partners. Commitment is not just to financial support. For example, managers are critical to enable the training cascade, for example, by helping disseminate information about training events. Poor communication could result in training being cancelled, local trainers being demotivated, and eventually the collapse of the entire cascade. At the super-organizational level, facilitators of taught can include financial support, infrastructure, for example, venue for training, and dissemination, particularly when the training takes place across institutional or regions. Taught interventions will succeed if they align with the individual's professional goals. This is key to avoid attrition among master trainers, but crucially among local trainers. Partnerships are rarely justified if their activities are not tailored to the local context and the local health needs. So a thought should feed into the training needs and organizational priorities of the developing country partner. A good alignment between the outcome of a thought and the organization's strategic objectives will result in greater management support for cascade activities. At the super-organizational level, alignment with regional or country priorities is also important. In this sense, establishing formal and informal coalitions of different organizations, hospital, district, professional bodies, can help influence the policy environment. The success of a thought depends on whether local trainers deliver and develop training courses. So a clear implementation strategy at the organizational or super-organizational level is really critical to cascade the training. This may mean, for example, making training mandatory within an organization or establishing educational programs that make use of local trainers. The implementation by local managers or government officials ensures the sustainable integration of the training into local policies, local processes, etc. In other words, what I'm trying to say is that the sustainability of a thought depends on the successful transfer of ownership to a strong local leadership. Finally, while it's important for trainers to have the right set of technical competencies, a thought must also help individuals develop soft skills, for example, the ability for constructive criticism, empathy, flexibility, etc. Key to this is giving local trainers the opportunity to conduct training under the supervision of a master trainer and do training together. However, because training of trainers are usually short workshops embedded into larger training programs, the opportunities for local trainers to conduct supervised training are limited. It also means that the emphasis is usually on the initial transfer of skills from the master trainer to the local trainer. So it's important to build into the partnership time to co-train and supervise local trainers and provide feedback. The sustainability of a thought ultimately depends not just on training the trainers, including this element of supervision and feedback, but crucially on avoiding de-skilling over time. Sustainable upskilling of the workforce requires opportunities for continued professional development to be integrated into the long-term strategy of the institution. This should include not only the ongoing mentoring that is at the heart of the partnerships, but should extend also to provision of access to relevant literature, further courses, and networking opportunities beyond the partnership. Nurturing local trainers should not be limited to the initial training, but should be gradually integrated into local mechanisms with increasing support from the partnership. So, in conclusion, I'm suggesting a framework or if you like, a tentative structure to measure the impact of thought interventions. This framework that I call TRAIN gives a blueprint and a structure. In practice, it might be impossible to implement TRAIN ops in its entirety. So some partnerships may have greater influence at the individual or institutional level, but find it more difficult to influence the supra or the policy level. It might be also that in some cases it's more feasible to address those elements of the TRAIN framework that affect the early stages of the cascade, such as the selection of trainers, that those that operate at the later stages, such as implementation and transfer of ownership, because these typically require more input or high-level input from managers and officials in the developing country. So although this is a framework that might not be feasible in all partnerships, I suggest that knowing what makes a thought intervention successful can help or can better help project planning and design. And with that, I thank you. And well, if you have any questions, I'm happy to take them at the end.
Thank you very much, Mara. That was great. Yeah, as we said, we'll have time for questions at the end. But yeah, it will be really good to see how partnerships can work with your framework to really sustain their training cascade. So thank you very much for that. It's also worth mentioning that we have actually done an executive summary of Mara's research, which is available on our website. So I'll make the link available for that at the end. So I would now like to present Charlene Lobo. And Charlene is the project coordinator for the University of East Anglia and the Ekwendeni College of Health Sciences Partnership in Malawi. And this project relies on training of trainers for their plan to develop the teaching skills of educators and nurses. So over to you, Charlene.
Thank you, Carmel. I'm just trying to get my screen up. Can you see me?
Yes, we can see you. If you just like to make it full screen so that we can have the full effect. But we can see your slides, yes.
Okay. Does that help? Is that better?
Yeah. That's...
Okay. Shall I begin?
Yes, over to you.
Okay. Thank you. Thank you, Carmel. And thank you, Thet, for inviting me. It was very interesting to hear Maru's presentation, as I think many elements of our project absolutely, I would say, fit your framework, Maru. So I hope we'll be able to demonstrate some kind of link here. So I'm Charlene Lobo. I'm a senior lecturer from the University of East Anglia in the School of Health Sciences. And this was a project that we started in about 2009, I think. And the aim was, as Carmel said, to adopt a training the trainers approach to develop the teaching skills of Malawi nurse tutors predominantly. I should add a little bit of context in terms of the background, in that we started this project with a visit from 2 lecturers from the UEA to Malawi. We had an already established partnership to explore and review their nurse education. And in this scoping exercise, we identified a major gap, being the notion of mentorship of student nurses. Now, in the UK, all student nurses are allocated a mentor, which is usually a qualified nurse, when they are in practice. Now, in Malawi, this was not so, and one of the problems that was reported to us by our colleagues in Malawi was that they had a high attrition rate of student nurses, because when they were in practice, they had no supervision, support, or assessment of practice. And this therefore frightened many of the students, who subsequently often left the course due to feeling unsupported in practice. And so one of the key areas that they were keen to develop was the notion of mentorship in practice. So the next stage of our program, when we got when we won the THET award, was we invited our colleagues from Malawi to view mentorship and to outline what they wanted in terms of the training. Now, this was actually a key area to one of our successes, which I will go on to look in more detail. Following that, we developed a 5-day course on mentorship to be delivered in Malawi, and we sent 2 lecturers to Malawi, who delivered the course in 2 sites, and so began the cascade. This is the process that we followed in Malawi, and really I'm not going to talk so much around this, but it was just really to give you an overview around how logistically we actually developed the cascade. So really, for my presentation, I'm going to concentrate on the things that made us this program successful, and to talk about some of the challenges that we came across. So really, one of the successes, and I would say, you know, it is a success because there were many occasions that I wondered whether we would succeed to complete the project. Often due to, you know, many unforeseen changes, as our project actually took, you know, 2 years is actually a long time to complete the project. So it was the key that made it success was the commitment of named individuals, both for Malawi and for the UK. One of the problems with this is that we found in Malawi there was a very high turnover of key staff. So, for example, you know, the project lead changed halfway through, so it meant that we needed to get a new person established in Malawi. And from the UK perspective, I was the lead, but there was no time that was fitted into my role within the university to support this project, and therefore, you know, there was a huge time factor in terms of resources that I had to find from within our already very finite resources that we had at the university. The second theme that came through for us was maintaining the integrity of the training. Now this was really interesting because initially we had planned that we would conduct the training so that we were linked to one school of nursing in Malawi, which was Ekwendene. However, the idea was that we should cascade the training through a number of schools in nursing schools in Malawi. Now, Malawi has two systems of nurse education. One system is attached to something called the Christian Health Association of Malawi, and they have 10 schools of nursing in Malawi. And there's another system that is supported by the government, and they have 3 schools of nursing in Malawi. So as we were attached to Ekwendene and CHAM, which is the Christian Health Association, we were going to cascade our training initially through all the 10 CHAM schools. But when we invited the initial group to visit us at the UEA, we were very lucky in that we had key personnel attend the UEA. So the key personnel we had was the head of the School of Nursing in Ekwendene, we had the chief nurse for Malawi, and we had the director of the NMC, which is the Nursing Midwifery Council in Malawi. And these 3 people were absolutely key in ensuring that we establish mentorship within the context of nurse training in Malawi. So the chief nurse and the director of the NMC were very keen that the cascade of the mentorship did not just stay with the CHAM schools, but also extended to the state schools of nursing. So therefore, we were looking at cascading the training throughout Malawi. But what we had initially planned was that Ekwendene, we would initially start the training in Ekwendene, and then they would cascade it to the other schools, and the other schools would cascade it to their mentors. However, it was quite difficult to ensure the integrity of the training because we realized that actually some of the concepts we were using were not very familiar with many of the nurse educators throughout Malawi. So what we did is we identified a core team within Ekwendene who went out and cascaded it to all the other schools. And we supported this core team. So the other issue that we identified, and for us it was around, it enhanced our ability to be successful, was how we made it a competency-based training. And it was actually about, we were very clear about what the skills were and how we practiced the skills. And this was slightly different to what we deliver in the UK in relation to mentorship training, where it was very much based on understanding education theory. And of course, you know, it takes longer to incorporate that theoretical understanding in your practice. And we supported our training with a lot of resources. So we had a lot of resources in terms of hard paper. And again, we had to have this because there were limited number of you know, computers and laptops, etc., available, especially in the rural areas in Malawi. So we had to have hard resources, but we also developed a CD training pack, and we were very lucky in that the involvement of the NMC right from the very beginning helped disseminate and deliver that to all nurse tutors in Malawi. So I think we feel very strongly that one of our biggest successes is our ability to ensure sustainability. As I said before, this was by inviting key members who were very keen that this was a very important gap within nurse education in Malawi. And at that time, the director of the NMC, before she left, ensured that the curricula as set by the NMC incorporated mentorship. So mentorship is now embedded between the professional requirements for nurse training in Malawi. So, you know, we feel that that's, you know, the main gap that we had identified in our scoping exercise was fulfilled. You know, and I think we've done quite well in establishing the training within nurse education. However, I think things have changed. It seems things have changed, and the director of the Nursing and Midwifery Council had left because she has completed her 3-year in her position, and we're not quite clear about how the dissemination of the CDs has been continued within the NMC. So for us, the main challenges have been the issue about recruiting the right number of participants to the training. Now, one of the ways we did it was, as I said, the commitment of the project lead in Malawi, and they had to work very, very hard to make sure that all the schools right throughout Malawi, you know, offered enough places. Now, again, we were lucky that the NMC supported our program, and they included this training as part of this, that it met the CPD requirements for all nurse tutors. So they were able to add this to their requirements for, you know, to remain on the register of the NMC in Malawi. So that was really helpful. But one of the problems in terms of recruiting the numbers and participants was, I think Maru referred to it in terms of resources. So we hadn't anticipated that there was an expectation that we would have to pay for all the transport. So nobody, you know, the attendees, if they were attending at any central point, we had to pay the cost of all the transport to that point and provide refreshments for the whole day for all the participants. And that's something that we hadn't actually originally built into the program. You know, with that, another challenge was the escalating costs through the lifetime of the process. And again, one of the issues was about fuel and access to fuel. So this affected us in 2 ways. One, about getting the number of participants to the training days, and secondly, getting the trainers out to the different areas, the core team to the different areas to actually deliver the training. So both those combined really impacted on the extent by which we were able to extend the whole program. And I think for us, one of the greatest helps in this was actually THET's ability to be flexible in changing our proposal as the landscape changed. So for us, it meant instead of delivering our program to the whole of Malawi, we were able to focus and to focus it to just the northern area of Malawi, and with that respect, we achieved quite a high number of training the trainers. Constantly through the program, I think the change of staff in relatively new organizations, especially for Malawi, did impact and provided a challenge throughout. So, for example, the head of school in Ekwindeni changed. The project leads, who were the people who were appointed as the project lead, changed. And I think for us, a key issue was actually maintaining communication. And I think for me, this very much fitted your point, Maru, around nurturing and providing that mentorship. The ability to keep in regular contact was constantly challenged. We often didn't have good telephone communication. We didn't. Skype was interrupted. Sorry.
Hi, sorry, Marlene. Just one more minute, if we could, if that's possible.
Okay. Yes. Thank you. I've nearly finished. So communication was an issue, and I think for us, evaluation was a challenge. So getting the returns consistently, and also it was really important. We didn't have scope to evaluate. You know, it would be good to have included in the evaluation what's happened 1, 2, 3 years following the introduction of our program. So I think that's kind of our experience in a nutshell. And I presume Kama will take questions at the end, or?
Yes, questions at the end.
Okay. So thank you for listening, and I hope that gives some insight to future programs. Thank you.
Brilliant, thank you, Charlene. You've clearly achieved a lot despite some challenges, but it's really good to see how you've identified the solutions to the problems that you've encountered. That's really great monitoring and learning. And yeah, your approach to ongoing evaluation is really great, and it's something that we encourage all partnerships to do. So thank you for that. So our next presenter is Lizzie Rafi Tobar, who is actually with us in the THET office today. And Elizabeth is the project coordinator for the partnership between the Royal College of Obstetricians and Gynecologists and the Kitovu Healthcare Complex in Uganda, which aims to improve the delivery of emergency obstetric care. So I'll just put Lizzie's slides up. There you go, over to you, Lizzie.
That's great, thanks, Carla. It's just me, I'm afraid, today. Rachel's not with me, so I'm going to talk you through our project in Uganda and focus on what we've been doing to embed skills locally, and particularly with looking at master trainers for obstetric emergency training. So just to give you a quick background to our project, the objectives were really for the embedding and cascading of skills and knowledge of the management of obstetric emergencies. And we've done this through practical means and theoretical. So there is a 3-day course for health workers in maternal and newborn care. And the course focuses on lectures and then practical skills, looking at management of the main the main issues around maternal and newborn morbidity and mortality in Uganda. Our project has a particular focus on preventing obstetric fistula from occurring, and that is looking particularly at the management and prevention of obstructed labour. Within this project, there's been obviously a strong focus on behaviour change. So the idea that we obviously want to transfer skills and knowledge, but it's also about how people who have been on the course put that learning into practice when they return to the health centre. And part of what we've been doing is working with a sister organisation called the Change Exchange through FET, and they've been very instrumental in supporting how we look at motivational factors, for example, and helping to make changes in the health centre. And finally, the big part of what our project has been about is about focusing on embedding skills locally. So in the latter stages of the project, we've been looking at master trainers training. And what we've done is to support these trainers is grounding the master training in evidence-based medicine, really around supporting when challenged with issues of, oh, we've always done it this certain way, and how to help people to see why we do certain things based on evidence. So to give you a few statistics, in terms of meeting our objectives, originally we'd set out to train 320 health workers in the region of Masaka in rural Uganda. However, we found that because we've done 10 courses, 32 people in a course was simply unmanageable when doing practical skills training. So we've reduced the course size to about 28 to 30 delegates per course. So we've actually probably trained about 300 health workers. We've actually then trained more trainers than planned. We run a train the trainer day at the end of every 3 days of training. So we've run 10 train the trainer days, and we've trained about 5 on every course. So that was more than we'd originally planned. We also saw, as the project progressed, that there was a real opportunity to train master trainers. So with the train the trainers, obviously we want to encourage local professionals to cascade the training within their own health centres. But thinking about sustainability, it was really about having a group of master trainers to support the ongoing teaching of trainers as a course. So this led to our application for a knowledge and sustainability grant to FET, and we were successful in achieving that. And so we're using that to further hone the confidence and teaching and showcasing of the course by our master trainers, and we have 12 who have come from a range of health centres and are a range of cadres as well. The course has involved UK volunteers, Ugandan faculty, as I've mentioned. We have a project manager at our partner hospital at Kitovu, and we've also had an M&E consultant who's Ugandan, who's been supporting volunteers to do the M&E of the project. And as the projects evolve, our partnership has grown to be with a group of master trainers as well as with the hospital. This has helped us develop a link with the local regional referral hospital in Masaka, which was our hope, and we're very pleased to have done that through a obstetric consultant there. But we also have Kitovu health workers within our master trainers group. So in terms of what's been going well, we've had really good engagement with our master trainers. They're extremely enthusiastic and have really taught us how they would feel it's possible to take this training forward beyond the life of the 2-year project. We've been very pleased that the focus on prevention has been strongly taken up, and this was really a big part of our project, that we wanted to prevent emergencies from happening, and that patients are a lot easier to manage before an emergency happens. So looking at things like early warnings, use of the partograph, we've seen some evidence that's really been taken up well. That evidence has been shown to us through quantitative and qualitative responses. So we've had some evidence from the regional referral hospital that there's been a reduction of sepsis and stillbirth through use of the early warning system. And we've had a lot of qualitative evidence. Also, we were actually present at a hospital doing some M&E where a patient came in with malaria, and we actually saw the early warnings in action, we were told afterwards by the health workers who managed that patient that had been completely critical to the management of that patient. The change exchange, as I mentioned, have really become part of our faculty, which has been excellent. And we've learned a lot about motivation for behaviour change through them. And the master trainers particularly have really benefited and enjoyed the participation of the behaviour change scientists within the project. What's gone less well is sometimes with our action planning. So we encourage all of our delegates to complete an action plan of what they want to put into practice when they go back in their health centres. And this idea of reflective practice isn't something that is used as widely in Uganda, so it's taking a little bit of time to get set in, but we're persevering with that. We've seen some issues with skill retention during our monitoring evaluation that sometimes health workers simply haven't had the opportunity to practice because they don't have the equipment available, so that's been one of the issues within our project. And then also gathering data to see how our projects had an effect is not always as straightforward as we hoped. So gathering things like referral data can be quite a challenge. And also gathering the evidence of the impact on levels of obstetric fistula is difficult because we feel it is too early to tell. And the fistula patients that come to Kitovu come from such a wide area outside of Masaka, it's not always possible to see a direct impact of our project on that. In terms of phasing out, what has been effective is that we have our master trainers group, and we ran a master trainers course for them specifically. They'd all done train the trainers training before, but then we did an intensive 5-day course, and then that led on to them fully teaching and leading the last 2 main courses of our project in September, and we had UK observers, so that was excellent to see them leading the course. We've been doing something called faculty gelling, which I will explain a bit more about in a second. Also, we've noticed there's maybe a little bit of tension. I think when you have volunteers supporting and teaching a course, there can be some tendency to be quite difficult to let go. And we've been very, very kind of insistent that, we want to hand this over. And now that we've managed to go through that process, it's actually been really effective. And I think it's given our UK volunteers a real insight into kind of the ownership being handed over, which is what we'd intended to do all along. And something that we're doing with the Knowledge and Sustainability Grant is that we are running another course now being led by our Ugandan faculty in December in another district, which has a really high fistula rate. So we're hoping to extend the skills there. And in March next year, we are going to be showcasing the project through our Ugandan team, and we're having a conference in Kampala to show the impact that this sort of type of training can have. And we're hoping to encourage district health officers from Uganda to come in and to join us for that. So what is faculty gelling? So the reason this came about is because of how our health partnership has evolved over time. And our master trainers, this group of 12, come from all over the Masaka region. So we felt there was a need to have a bonding experience between the trainers who are then going to be working together very closely. We also felt it was a really good platform for learning for us as the UK partner, because we want to understand what the Ugandan faculty's vision for the future of the project looks like. We also felt that it was a really good way of creating a platform of equality between the master trainers group, because they're all different cadres. So we've got midwives, nurses, nursing officers, clinical officers, medical officers, and an obstetric consultant. So we just felt that by having a platform for them all to share their own vision was going to be a really good way to get the multidisciplinary team working even more strengthened. It was also a good way to talk about the challenges of teaching the course to other colleagues, so understanding what's been going on in their own health centres and how we might be able to make that easier. So the way it's worked is the UK volunteers have attended and facilitated, but really asked the Ugandan faculty to lead, and that's been a great learning experience. What would we have done differently? I think that what we've seen is that we are really pleased with how the master trainers training has gone, and the enthusiasm and the teamwork that they've built up with UK doctors as well and midwives. So we probably would have liked to have started it slightly earlier in the project, so that I think we would have done had we had our time again. The Ugandan faculty have shown a real interest in monitoring evaluation expertise, so I think it would have been nice to have started some M&E training with them a bit earlier, but we are taking that up and we're doing that at the moment. Also, we've found using evidence-based medicine, so looking at research papers with the master trainers and really bringing that to life with them has given them a lot of confidence, and I think we probably have liked to have done that within the main training of delegates as well. So I think that would have really helped potentially to inform behavioural change even further. And that's the end of my presentation. I'd be happy to take any questions that you have. Thank you.
Thank you very much, Lizzie. That was really interesting to hear about quite a unique TOT intervention, especially the faculty gelling. That's not something that's very common. So that was really interesting. And definitely let us know how you get on with the Kampala conference. That sounds great. Okay, so our final presentation will be from Kim Parker and Greg Harrison on behalf of the Sheffield Health and Social Care NHS Trust and the Gulu Regional Referral Hospital in Uganda. And they're delivering training in management of violence and aggression. So over to you, Kim and Greg.
Thank you. Thank you. We are just trying to... How do I get to... Can you hear me?
Yes, we can hear you.
Hello?
Hi, can you hear us?
Okay, thank you. Yeah, we are experiencing some difficulties with sound, so if we do go quiet, please can someone just let us know if we've missed anything, because we are getting dips in sound on this side. Okay, thank you. So our
oh, Kim, we can't actually see
presentation is it's on the screen.
Do you need to click on to show my screen? I'm just guessing.
Yeah, if you just click show my screen. Brilliant. Yeah, thank you very much.
Okay, thank you. So we're going to talk about the Gulu Sheffield Mental Health Partnership and specifically the Train of Trainer programme that we've been running for some months now, supported by THET. Ours is a mental health partnership. We initiated the partnership in 2012 and we've had a patient safety focus ever since that time. Just a little bit about the ward. The ward is a mental health unit within a regional referral hospital. It's a 40-bedded ward for men, women and children, and it serves the north of Uganda and South Sudan. And it's an area of the country that was particularly affected by 25 years of civil war, which had a devastating impact on almost every aspect of life. I'm not going to go into too much detail about that, but almost every family in that area was directly affected or knew someone who was directly affected by the war. Mental health need in that area is very, very high. We have several work streams. The first work stream is Commonwealth Fellows. We've had 18 Commonwealth Fellows come over from Gulu, and they are from a range of cadres. They've all worked into our clinical services, and they've all taken part in our respect training, which is what this webinar is for us is mostly about. Our second work stream has been patient safety. We've worked closely with the University Hospital of South Manchester to provide acute illness management training. We've also provided yoga training. We've done some work on developing rapid tranquilization protocols, and we've looked at how to improve the physical health monitoring of patients. We also have a work stream with Mental Health Uganda, which is a service user group, a national service user group that has a branch in Uganda, and we've had a number of work streams there. And we work particularly into 3 villages, Bobit, Awatch and Abwatch. and they are areas of the district that are particularly affected by mental health need and have the highest rates of completed suicide. And the Respect training, which is the focus of the THET Award, has been our longest term commitment from the very, very first Commonwealth Fellows that came over right up to current time. Everybody does Respect training. So I'll say a little bit about why Respect in Gulu. As I said, all the Commonwealth Fellows have attended the course. One of the very first participants said to us, it's like moving from wrestling to dancing. We didn't realise at the time the gravity of what he was saying there, and we didn't appreciate at that time how violence and aggression and various levels of distress were actually managed in people who have mental illness or mental health problems. But we have trained the entire of the mental health unit in that time, and we've provided annual refreshers, and Respect has become a core part of our partnership. Some of the staff appear to genuinely not appreciate that kindness and talking to people was okay. And I think the fear of people with mental health problems being either possessed or some kind of witchcraft was making them behave in the way that they were, genuinely made the staff frightened and feeling that it wasn't okay to talk to people. And that's been a big shift, a big change for them. And from the onset, they asked for the training to be rolled out to the rest of the hospital. So the Respect training is about recognising signs of distress and anger, or what is the unmet need that's causing that person to feel upset, which could lead to distress, which could lead to aggression, which could lead to violence. It's about recognising all of that. It's our management of violence and aggression course that we use in our trust, and we've been delivering that to our staff since 2012, which was roughly the same time as our partnership started. The emphasis is on de-escalation and communication, but we recognise that occasionally physical interventions are required, and there is a no pain, no panic principle. So none of the techniques rely on pain to be effective. And crucially, we do not train people to use the face down position. In the UK, there is a movement to try and end people being restrained face down, and following talking to our partners over in Gulu, they wanted to follow that as well. Face down restraint is a position of restraint most frequently associated with death. That's not to say that any restraint position is safe, because it's not, but it is dangerous to restrain people face down. So the course looks at stigma directly. One of the first things we do is to discuss how stigma can affect people and how that can make them behave in ways which they may not normally behave. We do use anti-stigma videos that are provided by the Bootabika Recovery College in Kampala. So the people in the videos are people who have directly experienced stigma themselves and talk about how that might lead to them becoming aggressive or violent. We look at the factors that can cause aggressive behaviour and how a very simple incident, completely unrelated, can cause an outbreak of violence or aggression. We call that the crisis cycle, and it's helping people to recognise how seemingly unrelated events can, if not de-escalated, build up into a serious incident. We spend a lot of time talking about that. We also teach people what to do when physical interventions can't be avoided. So if hands have to be laid on someone to manage them safely, how to do that in a safe manner without relying on pain. We talk about rapid tranquilization, how to physically monitor that person, and some of the health risks associated with restraining a person. We also have a session on the service user experience. So that is that talks about how an individual felt when they had been either restrained or rapidly tranquilized, and how that made them feel. It's a very, very powerful session for people to hear directly from a service user. And I think it's something that's perhaps not too familiar, listening to service users and about their experience. And it is a part of the session that has been particularly valued and powerful. So how successful has the work been? Well, we trained 9 people and we have retained 9 up to date. We're a year in. One of our instructors did leave to go back to nursing school, but he continues to be involved in the training. So every opportunity he gets, he will come back into Gulu and to work with his fellow instructors. And one of the senior sisters was promoted to a different district, but unfortunately for her that fell through, and unfortunately for us that meant she stayed. So we do have 9 instructors from a range of different cadres. We've got support staff, we've got senior nursing staff, the head of security is part of the team, physiotherapy assistants. We've got a range from across the hospital. And our original target was to train half of the hospital staff, which at that time was between 135 and 140 people. And we've also managed to keep the mental health unit up to date with their annual refreshers. So we are on track at this point in the programme to meet the numbers of staff trained. We are using a range of measures to work out whether the training is being effective or not. We have some validated tools and some more informal measures, so we have quizzes, tests. We use a pre and post management of aggression and violence attitude scale, which is a scale for measuring people's attitudes towards violence that was developed in the UK, but it has been used internationally. We have employed a researcher in Gulu who works very closely with our researcher in Sheffield, and they are reporting that some of the findings that are emerging are very positive about attitude change and have statistical significance. We have also received comments from some of the senior hospital staff, including their attendance on the course, which suggests that support from the hospital is good, or indeed high. The issue of incentives has been a significant challenge for us. I would say it's probably been the greatest challenge that we've had of this programme. Having been in partnership with the mental health unit since 2012, we had already addressed the issue of paying people to attend training, and many of our early conversations were based on them asking us to pay for them to attend training. We were new to the issue at the time. We took a firm line by saying no, without really realising at the time the cultural importance of why people were asking for payments. And so we underestimated the fact, I think, that when we started again with a new staff group, we would have to start again on the issue of payments. And I think we hoped that the trust that we'd established with the ward staff would transfer across, but that wasn't to be the case. Support from our existing partners on this issue has proved to be essential in helping the new trainers to move past the issue of financial payments and cash incentives. But for us, incentives have been an essential part of this programme. We did learn that we were being compared to some of the large multinational NGOs that do appear to pay large financial incentives and non-financial incentives to facilitate attendance at their training. And people often said to us that they had received payments from these NGOs to attend training, so why were we not paying them to attend ours? And significant negotiations have had to take place very sensitively over quite a sustained period of time. And it has at times felt touch and go as to whether we would actually lose any of these instructors or not. We had to take a consistent line, but did say that we were open to discussions about providing them with any items that would support them to do the training. We were asked to provide laptops and other very expensive electrical items. We had provided laptops and cameras and various pieces of equipment to deliver the training, but they wanted their own individual items. We had to persuade them that although we did have a small budget, we weren't rich, and therefore weren't able to provide the extent of the demands that they were making, and they did feel like demands at the time. We did provide t-shirts and other small items that helped them to identify as a team and gel together as a team of respect instructors, and we really tried to promote that sense of you are providing something very unique and very so special, and you are the only group actually in the whole of Africa that are providing this particular training. But rightly they told us that that actually didn't help feed their families, and it did take us a long time to get past the point of providing financial incentives. So we did have many discussions. Yeah, okay, we did have many discussions with them, and we are actually providing them with a range of items to help provide the respect training. It is an area that we did feel quite alone with, really, and I think it's been one of our steepest learning curves. What we would do differently is engage early with directors on both sides. All of the staff asked us for this, but we didn't actually talk to the director until we put the application in, and that is the same on both sides, really. We didn't talk to our directors here about our capacity to fulfil our commitment, and we have had some difficulties with staffing release here in the UK. I think we would have pushed more for the work to be included within the hospital's infrastructure, and we would have thought more about hierarchy and status. We asked one of the respect instructors, who appeared to be very popular with the group, but actually we asked him to be a respect lead trainer, and that was not well received by some of the other people, because his status and his position and the fact that he wasn't from the mental health unit did cause some difficulties for both us and for him. And of course communication is a very difficult challenge, being able to keep in contact with people. Informal communication has worked much better than formal communication. So in summary, the partnership is aiming for self-sufficiency in this, and we're hoping that on this next trip this weekend and the weekend after, they will be delivering the training largely by themselves with our support in the background. The trainer of trainer approach does appear to be very popular in Gulu. All of our trainers were selected from a prior course prior to the start of the THEC grant, so we were already on track with some of this work. 9 people started, 9 people finished, and we have retained all of those people. It was a 7-day consecutive course, very grueling. There is a physical assessment of the techniques. There is an acquired knowledge test so that we can be assured that they have actually taken in and learned what we have taught them. And we've gradually been handing over responsibility. And they did deliver their first independent course without anyone from Sheffield actually in Gulu in September. And that appears to have gone extremely well. We'll hear a lot more about that when we go out in the next week. So just 3 pictures, if I may. This is a picture of the touch support technique. People are learning how to deliver some of the training there. These are some of the respect instructors in the t-shirts that we've provided for them. And you can see the lady there is heavily pregnant. She's one of the nurse's sisters, but she actually managed to complete the course. And all of the respect instructors there saying hi. Thank you.
Thanks very much, Kim. You're clearly meeting an unmet need in Uganda, and it was really good to hear about the issues that you've had around incentives. And unfortunately, I think maybe quite a few partnerships can relate, but the advice that you've given has been really useful, so we hope that other partnerships find that useful too. And thank you to all of our presenters today. It's been really informative. We have run over slightly, but if anybody does have any questions, we'll have time for a couple of them. So I'll just take all the panelists off mute. Have any of the panelists got any questions?
Yes, can I ask
yes.
Okay, if we take Mary's question first.
No, please. I'll ask the question at the end if there's time.
Okay, does anybody else have any questions?
Okay, hi, I'm Greg Harrison from Sheffield. It's a question for Lizzie, really. We were very interested from Sheffield to hear about the role of the project manager and the consultant in monitoring and evaluation. So just a question for Lizzie, if she could tell us more about those two roles, please.
Oh, can you hear me? No problem. So our project manager is a member of staff at Kitovu Hospital because they're our partner, and she's actually the accountant at Kitovu Hospital. So she's been very instrumental in supporting with the logistical management of all of the courses that we've run in conjunction with the master trainers as well. So she's sort of been liaising between them and us in the last few months a lot more. She's also part of the monitoring and evaluation team. What we found is that it's quite useful to have her involvement. She's extremely knowledgeable about all of the local health centres and the staff of the health centres. So she's able to sort of connect our volunteers who've been going out to take part in the M&E work. In terms of the M&E consultant, when we initiated this project, we did have links with a consultant who's actually based at Marara University, and that's somebody we know through some other work that we've done sort of with a previous team. And she has a lot of experience of this sort of work and collecting data. So we asked her to support with the M&E, just because she's obviously an experienced professional in the field, but also you know, understands the local needs and the local issues. So she's been supporting UK volunteers, and as a team that they've gone out with the project manager and now with some of the master trainers to conduct the monitoring evaluation. So that's how that's come about.
Okay, thanks. If I could just ask whether the people were full-time or part-time, and maybe if we could get any more details from you, but by email.
Sure. Yes, I can liaise with Carmel. We'll get in touch with you via email.
That's great. Thank you.
Okay.
Great. Okay, and just time for one more question. Mary, did you have a question?
Well, if there's nobody else, I'm happy to ask a question.
Yep, go ahead.
Yeah, I was really interested about the issue around incentives in the Gulu Hospital, and I was just wondering whether you've explored other incentives or incentives other than payment, because that's one of the things that I came up with in this framework is, you know, the importance of aligning the training with the individual's, you know, aspirations. So clearly, you know, financial remuneration is important, but perhaps that could have been achieved through, I don't know, embedding the training within promotion paths. You said that you had a lot of support from managers. Would this have been an alternative to just making payments?
I think we were very clear we didn't want to leave the hospital with any additional expense. So to say that people would attend training, could be promoted, I'm not really sure that we were in a position to be able to say that. But we certainly, I mean, everybody that comes on the course gets a meal. It's a 4-day course. They get their lunch, they get the breakfast, they get drinks and refreshments throughout the day. We look after them really well. We do take the. I was interested in about the bonding experience. We do go out with them as a group of people for a meal at the end to celebrate the fact that we've completed another course. So we try to make them feel part of our team here. We are a team together, and we do things together. And But no, we haven't thought about promotion, because some of the people, because it's for all the staff in the hospital. It's not just for nurses. It's for everyone at every level. I'm not sure that we're in a position to be able to say that they could get something that the hospital would have to provide.
Yeah, of course, as it would have been. Yeah, no, my question was about, influencing managers at the hospital to perhaps incorporate the training into some form of promotion pathway, or basically my question was whether there could be other financial incentives other than just payments.
We haven't had any problem with attendance on the course.
Okay.
The need for incentive was from the actual instructors themselves, who saw that the role that they were taking on was additional to their day job, if you like. We don't have any difficulty getting people to attend the course. Every course is full and over.
Thank you.
Thank you.
Great, okay, thanks everyone. Unfortunately we have run out of time, so we're not going to be able to take any other questions, but if you do have a question that you wanted to ask, you can email either myself or Laura, and then we'll liaise with the panellists and get your questions answered. Yeah, so thanks very much everyone. We will put the recording on our website and our YouTube channel, and if you do have any suggestions for future webinar topics, then please do let us know. We're very interested to hear what you have to say about that. So thanks very much, and bye for now.